one of our target lines for research is based on assessment of benefits and harms of population-based breast cancer screening. And we have been developing this research line for nearly 20 years. And one of the key questions when we try to assess breast cancer screening is if it is efficient. Yeah, and by this we mean that actually, at least in Europe, all women aged 50 to 69, they are offered a screening mammogram every 2 years. Yeah, just for early detection of breast cancer. And the question is if offering a mammography every 2 years to every woman, that means one size fits all strategy, if that's efficient, or maybe if we should go a little bit deeper and try to personalize the breast cancer screening strategies. And when we talk about this, one of the key questions is the risk factors for breast cancer, which is the information that we need to use if we want to personalize breast cancer screening strategies. So for one of those key risk factors is benign breast lesions. And when we talk about benign breast lesions or benign breast disease, is the effect that they have on the as a risk factor and how long it lasts. Yeah, and that's one of the what we wanted to see in this study is how the effect of benign breast lesions, how long it lasts over time. Yeah, and we found that it lasted for 20 years and that the risk kept steady, stable for 20 years. And that's the key finding. To do this, we use retrospective cohorts of screened women in different areas of Spain. And we have a screening cohort which goes from the mid-90s to the actual time. So that means more than 20 years of follow-up of women who have been screened biennially, yeah, since the mid-90s. The key finding is that we know that previously that benign breast lesions are a risk factor for breast cancer, yeah, because we have published on that previously, and there are many other studies that contribute to that information. But what we wanted to demonstrate, and I think that's what is kind of new, is for how long this increasing risk lasted. And to do that, we need long screening cohorts, and that's what we have in our program and in our research, yeah, like this follow-up for 20 years. And we did a specific analysis where we wanted to check the effect of time over the risk. And what we found is that independently of how long the benign breast lesion, when it was diagnosed, the risk kept increased for 20 years, like with around a 1.8 relative risk. I think we have like two perspectives. Yeah, one is more like for the individual women, and I guess when we talk about that, we need to encourage women with risk factors, not only with benign breast disease, but maybe with a family history of breast cancer, that they should go to organize breast cancer screening programs. They should keep going to the screening programs because they may benefit more from breast cancer screening than women with a low risk profile. Yeah, so they should go to breast cancer screening. In addition, if we want to talk about making breast cancer screening more efficient, instead of the one-size-fits-all strategy that we are running right now, going to more detailed and personalized follow-up, then this information is very important because we can make risk groups of women, like to define women who are at a higher risk, who might be women with benign breast lesions, but also who may have a family history of breast cancer or a dense breast. If we have this information and we put it together, we can calculate the risk for each woman and put them in and say, this woman is a high-risk woman, is an average-risk woman, is a low-risk woman. So with this information, we can propose closer follow-up for women at a high risk. Maybe instead of a mammography, a screening mammogram every 2 years, maybe we should do it every year, or even more. If they have a dense breast, instead of mammography, we can use an ultrasound or maybe an MRI. So that goes in that way. But also for women who are at a low risk, that means that they don't have a family history of breast cancer, no previous benign lesions, fatty breast, maybe we can offer them a 4-year screening interval. That means instead of coming every 2 years, they will be screened every 2 years because we know they are at a lower risk of developing breast cancer. So all goes in line with personalizing strategies for breast cancer screening. It makes sense. I mean, what you just said is a key question in the actual debate. Yeah, if women at high risk should start the screening earlier, and I guess it really makes sense that they may, at least in Europe, the screening age range goes from 50 to 69. But maybe we should start thinking on doing a first assessment of risk for women who become 40, probably, yeah, around 40 years of age. We can check these risk factors like family history, do a baseline mammography to see if they have any kind of breast lesion, to also to check the breast density. And with that information, for those who are at high risk, it may make sense to start the screening earlier. For those who are at a lower risk, maybe we should wait until 50, because also the evidence from experts and from the evidence from the research says that the most efficient age range is from 50 to 69. So there is no conclusive evidence that screening 40 to 50 might be efficient, but at least for women who are at a high risk, it might be a legitimate question to start the screening earlier. I would like to highlight that we should not take the findings in these studies as an alarm. Yeah, like okay, women with a benign breast disease have a higher risk. Of course they have, but that does not mean that they are going to develop the disease. It means that they are at a higher risk. But keep in mind that the detection rate in a breast cancer screening program is around 5 breast cancers per every 1,000 screening mammograms. If they are at a double risk of breast cancer, that means that 10 out of 1,000 screening mammograms may be detected with a breast cancer for women with a previous benign breast disease. So that means they are at a higher risk. They should go to breast cancer screening programs, but we should not start an alarm, yeah, like saying that, oh, they are at a higher risk, because probably most of them, they will not develop the disease anyway. So just to try to send a calm message, yeah, to them.